Hello, everyone. My name is Danielle Regnier. I'm a psychiatric mental health nurse practitioner student at Mount Marty University in Yankton, South Dakota. And I am going to be talking about the COWS assessment tool as part of a quality improvement project. I'm just going to share my screen here. Okay. So the title of my project is Clinical Opioid Withdrawal Scale Inter-Rater Reliability Quality Improvement Project in rural Minnesota. It's kind of a mouthful. Okay, so a brief overview of the opioid epidemic. So in the mid-1990s, the American Pain Society declared pain the fifth vital sign to push providers to adequately treat pain. In 1996, Purdue Pharma released OxyContin, and drug reps were suggesting that only 1% of patients had the potential to become addicted to narcotic pain medication, and this is the statistic that was used by Purdue to market their OxyContin. In the early 2000s, physicians began to be held accountable for undertreating pain, and by 2017, the government declared the opioid epidemic a public health emergency. So just some statistics. An average of 221 people die every day in the United States from an opioid overdose, which equals about one person every 6 to 7 minutes. This chart over here talks specifically about emergency departments in Minnesota and non-fatal overdoses. So in 2021, Minnesota ERs saw over 13,000 admissions for non-fatal opioid overdose. And the emergence of fentanyl has really driven this overdose crisis, and it's claimed the lives of more than 100,000 Americans, and that was just in 2022 alone. There was really a huge spike in 2022. So opioid tolerance can occur in as little as 2 weeks. It can sometimes occur before that as well, just depending. Tolerance usually occurs where they're requiring higher doses to achieve the same effect, which kind of leads to that downward spiral. Opioid withdrawal symptoms can start in as little as 4 hours, usually peaks around 72, and acutely can last up to a week or more. There is something also called post-acute withdrawal syndrome, which can last for months sometimes for some patients. Signs and symptoms usually include sweating, tearing, goosebumps, nausea, vomiting, diarrhea, muscle cramping, bone pain, muscle pain, restlessness, abdominal cramping, and tachycardia. Patients have said to me, it's like the flu times 1,000. My bones are going to crumble if I stand up. I've had patients say I would rather die than feel this way. So once we know that patients are in withdrawal from an opioid, it's important to obtain that baseline COWS score. And you can find the COWS flow sheet under flow sheets in Epic. All you need to do is type in COWS, hit enter, and it should pop up for you. So once you do that, get that pulled up, you're going to want to obtain baseline vital signs too, as well as urine drug screen, and always include a fentanyl test on that. CCM Health does have the ability to run that urine fentanyl screen separately, which we're pretty fortunate to have that because there's a lot of facilities that do not. They have to send it out. So just making sure that the physician or provider that you're working with in the emergency department knows that that's available. Keep their environment calm, dim lighting, warm blankets, and encourage fluids, because a lot of times by the time they're coming to us in withdrawal and not feeling good, they've had poor intake, nausea, diarrhea, vomiting, things like that. So encouraging fluids is important. So this is what the COWS flow sheet looks like. It's a validated 11-item screening tool to assess the severity of opioid withdrawal. It does have both subjective and objective questions on it. Those objective questions are really important as they help determine the level of physical dependence that that patient is experiencing. Be sure to score based solely on the relationship to opioid withdrawal. So an example of that would be if the patient were to be pacing around or jogging, then their elevated heart rate would not count towards their score. They've got to be resting for at least a minute before you can obtain that. Be sure to read the fine print carefully to ensure correct scoring, because it does have specific questions in there, like during this assessment or within the last half an hour. There are different categories for scoring. Mild is between 5 and 12, moderate 13 to 24, moderately severe 25 to 36, and severe is going to be 36 or greater. If a patient is started on buprenorphine or Suboxone while they're in the emergency department, then that COWS needs to be repeated 30 minutes after that first dose. If they're going to be dosed again, say they're going to go up to like 2 milligrams total, then every time you dose them, then 30 minutes later, you're going to do that cow's assessment. And then say you reach that 2 milligrams, you do that 30-minute assessment afterwards. And then you let the provider know what the score is. And then it only has to be every 2 hours after that, unless the provider is wanting it more frequently, if they're not responding well for some reason, or you're doing a lot of other like baclofen, Zofran, things like that to help with their symptoms. And it really does just vary case by case, depending on how much the patient was using, especially if they were using fentanyl and in large amounts. If the patient's being treated symptomatically and they're not going to do medication-assisted treatment, then the cows should be repeated per provider discretion based on those medications that you're giving. So you're going to give Zofran and baclofen. Well, how long do those take to work? You figure that out, you're going to redo the cows again. So here's just a little scenario. Patient presents to the ED in active opioid withdrawal. They report their last use of fentanyl was approximately 12 hours ago. The patient is frequently shifting on the bed and rubbing their knees and calves. They have tearing of the eyes, frequent blowing of their nose, facial flushing noted, as well as clammy skin. Their resting heart rate is 110. Patient reports frequent bouts of diarrhea, but nothing within the last half an hour. However, they do report constant stomach cramping. With outstretched arms, they have a slight tremor that's noticeable, and the patient is notably irritable and is short with Rider during the assessment. Patient has prominent piloerection, and they have their eyes closed for most of the assessment, but their pupils do appear to be normal for room light. So then this is what the scoring for that would look like. So because their heart rate was 110, they're going to get a 2. Because they had flushed, clammy skin, they're going to get a 2. Because they had frequent shifting, for restlessness, they would get a 3. Their pupil size was normal for room light, so that's a 0. They were rubbing their knees, their joints, their calves, their muscles, things like that, so that would be a 4. Their nose was constantly running and tears were present, which is a 4. They reported those stomach cramps, so that would be a 1. They did report that diarrhea, but because it wasn't within a half an hour, we don't count it. We can only count the stomach cramps. They had that slight observable tremor when they had their arms stretched out, so that would be a 2. Yawning, I put at a 2, which would be 3 or more during their assessment. Now to get 3 on that, which is the highest, they would have to just be consistently yawning for at least a minute. Anxiety and irritability, they were obviously irritable during their assessment, so that would be a 2. They got the highest score possible on goose flesh skin because they had that prominent piloerection. Their total score would be a 27, which would be moderately severe withdrawal. They would definitely be appropriate for Suboxone or medication-assisted treatment if they wanted to go that route. Inter-rater reliability. So why is this important? It provides that consistency in scoring, which can impact patient outcomes. This is especially important in an emergency department where there might be multiple observers coming in. So nurses, doctors, what have you, might be, one nurse might do the assessment the first time, but then it could be a different nurse the second time. And so if everybody is trained the same way, it really can impact the patient. So incorrect scoring could also lead to adverse patient outcomes, especially if you guys are going to start something like Suboxone, because if they're not in withdrawal enough, we can push them into something called precipitated withdrawal, which is basically withdrawal on steroids. And it's really hard to bring a patient back out of that once they are kicked into it. So accurate scoring is extremely important in these situations. So prior to discharge from the emergency room, this is really that big window of opportunity. If they're going to go to a detox, you still have this talk with them, but especially if they're going to discharge back into the community, educate them on their high risk of overdose due to being naive. So say they came into you and they came by ambulance or something like that, and they were just reversed with Narcan, or they came to the ED on their own, abstaining from using, and it's been 72 hours since they last used. So if they left and they tried to use the same amount that they were using before they became naive, they're just at it extremely, they could overdose and die. So just knowing, making sure they're aware of that. And do not let them leave without an overdose prevention rescue kit. These are located in the Omnicell in the emergency department. Each kit contains 2 nasal Narcan, gloves, mouth barrier, instructions, resources, and fentanyl test strips. There is instructions on how to use the Narcan in there, and it's really layman's terms, very easy to use. Same with the fentanyl test strips. There's even like a QR code that they can scan on their phone, which will bring them to a video on the Steve Rumler website on exactly how to test a substance. I always use like a cookie analogy, chocolate chip cookie. You know, if you put a chocolate chip cookie in a bag and there's crumbs in the bottom, one of those crumbs might have a chocolate chip in it and the other one might not. So same with the fentanyl pill. So, you know, they might be testing one piece of it and that might not have fentanyl in it, but there could still be fentanyl in the pill. So they're not foolproof. It's important for them to know that. It's just a harm reduction tool for them to use if they so choose. And these are my references. So thank you for taking the time to watch this. I hope you found it beneficial for you. I'm going to stop sharing my screen here. And if you could just take a couple minutes here and complete that post survey, I would greatly appreciate it. Thank you.